Let's shift gears a bit and do a few cases. And I'm going to put these cases out there, and we don't have to agree on how to manage these patients. So 60-year-old presents to your clinic sort of urgently because has been found by a primary care to have symptomatic metastatic colon cancer, some abdominal pain, liver mets, lung mets, primary in place, not obstructed. And that's all you know. Colonoscopy, biopsy, adenocarcinoma. So you got a little snip from a colonoscopy. And you have a CT scan that shows everything. Otherwise, great performance status patient, but symptomatic and not feeling good. No Metaport in place at present. Shows up in your clinic. Let's make it a Thursday. You have Thursday clinic?
Yes.
So there we go. I got it right. So what happens to this guy on Thursday?
Well, with metastatic disease and no real symptoms, we're going to start with treatment with chemotherapy.
This guy's symptomatic. Oh, no symptoms from his primary.
The primary.
Yeah,
so
okay.
we're going to start treatment with chemotherapy. So I guess the main questions are which combination you would use, FOLFOX, FOLFIRI, FOLFOXIRI, and which biologic. If we're going to consider using an anti-EGFR antibody, one of the two that are approved, we're going to have to get the RAS status before we start, so that's going to take a little bit of time.
And the GI, was a community gastroenterologist, so it went to some lab in Arizona.
Where they did KRAS, codon.
No, they didn't.
12 and 13 only. They didn't even do that. So one thing I really want to point out today is that stop sending your samples for KRAS, codon 12, 13 only. We need to test both KRAS and NRAS and exons 2, 3, and 4 of both KRAS and NRAS. We need the complete, it's not the complete, but we need kind of the extended RAS profile, because the patients who have the less common KRAS and the NRAS mutations, it's another 15% of patients, and they also do not benefit from the EGF.
So a lot of places are doing that
antibodies.
Reflexively,
Yeah.
right? So they're doing, in-house because they set it up. They're doing the KRAS, and then if wild type sending out or having developed internally, what are you guys doing? Sending out the extra or doing it all internal? So you own your molecular testing.
We do.
Right.
You own it.
Yes.
We rent it. Do you?
This is the biggest challenge in the community, for both lung cancer and colon cancer. Remember, the colonoscopy can be one lab, the liver biopsy can be another lab, and the pathologist is really blinded to what happened to another sample. We looked at reflex testing, systemically, and to reinforce all RAS testing. Cost effectiveness can be a real challenge. So in the real world, what happens is the pathologist will put a statement, RAS testing available upon request, especially when the sample, because you don't know if it's stage 2 or stage 3, if it's a colonoscopy sample, and if it's a metastasis sample, you don't know if the testing has already occurred on the primary tumor. So we don't want definitely to duplicate, talking about cost effectiveness. So the warning in the report about the test available upon request, pathologists are involved with us about the evolution. It was not that long enough we were doing just PCR testing for certain codon, and now we want all RAS testing. So they're up to date when it comes to requesting the test. The second thing is the turnaround. We used to think it's about 4 to 6 weeks. I can tell you, if I start patients, I tell my patient, we start the salad, we add the dressing, we add the biologic. By cycle 2, we have already not only known and decided which biologic, but we got insurance authorization. Because remember, the challenge is at all those levels. So I don't believe 2 weeks delay in adding the biologic is going to make a major difference, unless for whatever reason the treating physician decides from the get-go he wants to use anti-angiogenic like bevacizumab with a cytotoxic frontline. But there are some other scenarios we can discuss why you want to use maybe an anti-EGFR in the frontline.
Yeah, so Rich, I was taught that you're supposed to biopsy metastatic disease the first time, but scans and CEAs and PETs and sort of inevitability, I guess, we've gotten away from that. But now there's more molecular variability in our patients. And You know, in a breast cancer patient for HER2, it's in their guidelines that you got to biopsy that met to show that that's really. Where do we stand as a colon cancer world about, is the primary good enough for RAS testing? Should we go after that liver met and test that?
So I would say yes and yes. So I think that the primary is good enough for initial treatment decisions, but that often later in the patient's course of treatment, I'm looking for a fresh biopsy, not just for EGFR status, but for full molecular testing. And a patient like this, I would be anxious to get that Metaport in and get them started on therapy early next week.
Yeah.
And I'd be happy to start them on FOLFOX. If they're not bleeding, FOLFOX Bev would be a reflex for me. We have a clinical trial of FOLFOX plus aflibercept that would be an option for a patient like this.
Phase 2?
Phase 2. I'd be, in most cases, delaying the use of an EGFR inhibitor anyway. And part of the reason that I do that is I feel like it gives you more options in later line. And also in those patients who are sensitive to the EGFR inhibitor, it seems to me that often they have a prolonged time to progression that can be really useful in the patient that is in second or third line of treatment. Even if it's a minority of patients that manifest that long progression-free survival.
Yeah. You want to get the patient treated. I think we all agree
Yes,
to that.
yes.
How and let's magically put a Metaport in. On Monday it goes in. And what are you going to give? What you think?
Well, our general approach is to start mostly with FOLFOX and bevacizumab also, and save the anti-EGFR for later lines. I mean, we've got a second-line trial, which I will unabashedly promote, ECOG 7208. I'm the national chair. Send in your contributions. We'd like to finish this study already. But that's looking at...
We just opened it.
Good, thank you. Send in contributions. Looking at ramucirumab plus cetuximab with irinotecan. So the development of the anti-EGFR antibodies, both of them really started at later lines and kind of worked their way forward. And based on the latest phase 3 data from the 80405 trial, there's no real imperative to give those first line. Doesn't seem like any subset you really gain a lot. I mean, you can give either one, seems equivalent. So in our case, we kind of save the skin toxicity for later lines.
Why isn't this a FOLFIRINOX Bev patient?
Well, so that's my other option. If somebody's really symptomatic or they have borderline resectable disease and they're pretty good shape, I would tend to go with full FOXIRI. And the update on the TRIBE data from the TRIBE study data from this ASCO confirms what they reported the first time, that it seems to have a very good effect on response rate and PFS in all molecular subtypes, including BRAF.
I mean, it was the highest PFS number we've seen. It's 13 plus months, and then it has an OS as well, or at least trend that way.
Trend, yeah.
Yeah. My only negative to using the kitchen sink, if you will, is that then what?
Then
Yeah,
what?
So,
that's my
but
problem
so,
with it.
this is a guy I might say, you give 3-4 cycles, get him off the ledge.
Right.
I've burned my trial options for those of us who, want our portfolio of studies. But it is a tool in the absence of a RAS, So 80405, I thought said that, like you just said, doesn't really matter. They're all pretty much the same. So we're still hearing a lot of back and forth around, if RAS wild type, I'm going to use EGFR, and if not. But I tend to be more like you guys. I tend to be more Bev. Is there, I think when we see that
We need to
positive reinforcement of a RAS testing, that's the right drug to use.
Just to be a bit different, for the sake of this round table, I still, look at the 5-3 data from a different perspective. And if this patient had a rather oligometastatic disease, I am more inclined at really wanting to know the KRAS and RAS anti-EGFR. Of course, there is no conclusive data that this is the way to go. The EPIC study, was, not conclusive. The advantage of using an anti-EGFR, we all, want to believe in the depth of response. Extreme, a few millimeters on a liver resection make a difference for a surgeon, on that caudate lobe of liver, etc. And second thing, I don't have to worry much about holding the anti-angiogenic for these 4 to 6 weeks before surgery and after. So it gives you a better, smoother treatment. You may drop the cytotoxic, keep the anti-EGFR. That's a subpopulation. Another subpopulation that for me is those rectal cancer recurrence, the pelvic recurrence, where size does matter when it comes to a pain syndrome on the sacral plexus, etc. I'm biased more about using the anti-EGFR.
If I gave this guy significant peritoneal disease, change your mind?
Well, again, I think by the time people get significant peritoneal disease, they aren't really usually in great shape to get the FOLFOXIRI. But, most patients can tolerate a few cycles of it, or maybe up to 8 cycles. That's a trial we've been doing looking at sequencing, the STEAM trial, where we gave FOLFOXIRI versus alternating FOLFOX/FOLFIRI versus FOLFOX as the control. So a little different than TRIBE. But, the tolerance has been pretty good for most patients. I mean, if we are used to giving pancreatic cancer patients FOLFIRINOX, I think FOLFOXIRI for your average colon cancer patient isn't a big stretch. But again, I think looking on the continuum of care, that's really the question. Is it better to give it all up front or have a sequential approach? And just for what Fadi was talking about, I don't know if everybody kind of followed the data that he was talking about was from a European study called FIRE3. And in that trial, unlike the larger US trial, the FIRE3 trial showed that the EGFR antibodies had a benefit in survival only. And the survival started to show up about at the 3rd year, so much later after the treatment was done. For some reason, the patients who had the anti-EGF antibody had a benefit, and if you looked at the extended RAS subset, the benefit was even more. So this did not turn out in the 80405 trial, so my personal feeling is that the FIRE3 study is probably some kind of statistical fluke, because I don't understand what biology would land up with that result. But the Europeans are much more in favor of the data they generated and tend to believe it more.
I think the devils is in the details between
Yes.
American and US studies
Yes.
about subsequent line of therapy.
lines.
So
Right.
that may be a
part of it.
component. And that's why I think the FOLFOXIRI BEV, I see it more into the setting where patients are less likely to get the chance for a second line or even third line. Maybe it's appealing, but it's hard to analyze when we don't know all the details about subsequent line of therapy.
So, Rich, do I get a vitamin D level on this guy?
Yes, you do.
Yes, I do, huh?
Okay.
Why would I do that? That sounds crazy.
Well, so there's actually some interesting data in advanced disease from our friends at Dana-Farber, again looking at retrospective evaluation of some studies, suggesting that patients with higher vitamin D levels had longer progression-free survivals and longer overall survivals than patients with lower levels. Now, when you're doing this advanced disease therapy, you're walking a tightrope in a patient like the one that you described. And trying to stay on the tightrope is really difficult. So you balance the issue of, do I use 5 drugs versus 4 drugs versus 3 drugs on my first cycle? Or do you use a smaller number of drugs, see how the first cycle is tolerated, see if that abdominal pain is starting to ease, and then use just enough drug to keep that patient improving symptomatically versus going all in. And I have to admit that I might see that patient at 2 weeks, reassess them, how did it go, maybe I'll add that other drug if I'm worried it's not going right. But the whole issue of non-chemotherapy, non-targeted drugs like aspirin and vitamin D in advanced diseases is an interesting question. And I honestly believe that the vitamin D data is consistent in the adjuvant setting, and here's some provocative data in the advanced disease setting, and I'll bet there's truth to this story.
Yeah, so what
But
I
that's a
would,
little different than saying that the study shows people who have higher vitamin D levels do better.
Right.
But that's very different than saying if you give vitamin D therapeutically, if you supplement vitamin D, therefore you will change the outcome. You really need a prospective trial to do that, and the vitamin D might be just a marker for better biology, more time
Can't
outdoors,
Kids
disagree
more
outside,
robust.
exercises,
Right.
right, yeah.
I
You
can't
know,
agree that-
especially in Boston, you got to run 2 hours to get your vitamin D level.
That's true for colon cancer, but to put things in, I'm a big fan of and follow the vitamin D story. But there is data about outcome, correcting the vitamin D levels and outcome in the stem cell transplant patients, CLL patients, lymphoma patients, and now that is ongoing with the breast cancer population, at least tolerating the aromatase inhibitor when it comes to side effects. So the vitamin D comes a bit of universal in the oncology space. It's not just about bone health. There is maybe a role of outcome, carcinogenesis, we don't know. If you have lower vitamin D, are you more likely to develop cancer? We don't know that. We know about the outcome. You're absolutely right. But for the sake of all of the above, I think it's good to check the vitamin D level to treat it. Of course, that's another debate if you want to treat what is the normal vitamin D.
Well, and the study, I think, showed the highest quintile had, so you got to get it up there. It's not just an average one.
I
You
get
have
it
to be a
above
vitamin
50.
D donor, right? I mean,
I get it above 50,
Yeah.
but I got a couple of patients with kidney stones too, so be careful with that.
okay, so.